and we are so happy today to have Dr. Downing joining us from Texas A&M Center of Excellence in Forensics. She will be sharing on trauma-informed healthcare and why it matters. Dr. Withy is not here today, so I will help facilitate the chat. So please feel free to drop any questions or comments in the chat, and I will relay them over to Dr. Downing. Without further ado, I will hand it over. Mahalo for joining us today.
Howdy, everyone. That's how we greet people from here in Texas, and particularly Texas A&M. I'm really excited to be presenting to you today. I'm a forensic nurse. So if you don't know what that is, it's a nurse who has specialized education in providing care to patients who have been impacted by interpersonal violence or non-accidental trauma. So I see primarily patients who've experienced sexual assault across the lifespan, also intimate partner violence, sometimes physical assault like gunshot wounds, and some one-offs like some non-accidental boat person altercations and some weird things. But a lot of what I do is providing care to victims of sexual assault and domestic violence, where trauma-informed care is quite key to what I do. I also teach in the Center of Excellence in Forensic Nursing at Texas A&M in our master's degree program, and I conduct research. Particularly, I'm trying to look at interventions that help people cope with trauma and mitigate or prevent symptoms of PTSD after traumas such as sexual assault. I've also done some work with people with opioid use disorder, and really was drawn to that because of the intersections, right, between history of trauma, substance use, and vulnerability to interpersonal violence when you are a person who is struggling with substance use disorder. So a lot of overlaps there, and I look forward to talking to you more about this subject. So I'm going to go ahead and share my screen. It's going to be kind of a wild ride. It's going to go fast, and because there's a lot that I want to talk about, and I'm going to try to move it so that I see that you see the
It looks good.
there now.
Oh,
now you've switched. Yeah, I'm trying to make it so that I am looking directly at you, but I need to share the other screen. So hang on just a second. Sorry about that, little technical difficulties. Screen 2. All right. So are you seeing the full-on show version now?
perfect.
No. Okay, great. So trauma-informed healthcare and why it matters. So for primary healthcare providers, our objective is to enable health systems to support people's health needs, right? From health promotion, disease prevention and treatment, rehabilitation, palliative care, and more. Also ensuring that healthcare is delivered in a way that is centered on people's needs and respects their preferences. So that is a goal of primary care, and why we all practice in primary care settings of one kind or another, or maybe you are in acute care. So what exactly is trauma-informed care? So this is my definition based on a combination of the Substance Abuse and Mental Health Services Administration, or SAMHSA's definition, and other places where they have articulated what trauma-informed care is. It really refers to personalized healthcare that recognizes the trauma is common and it impacts patients' health and their responses to healthcare, and also the behaviors that we as healthcare providers and healthcare personnel can do to prevent further trauma to patients with a history of trauma. Well, SAMHSA really has outlined the 6 principles of trauma-informed care. You may have heard of these, and we'll go through them in a little detail. And they are safety. Safety is always number 1 in the healthcare field. Trustworthiness and transparency. Peer support. Collaboration and mutuality. Empowerment, voice, and choice. and an appreciation of cultural, historical, and gender issues. So SAMHSA also describes the 4 R's of trauma-informed care. So how do you remember what to do when you're providing trauma-informed care? So it really relates to realizing, recognizing, responding, and resisting re-traumatization. So we'll talk about what each of those mean. First of all, it's really critical to realize that trauma is common. In 1996, the World Health Organization declared that violence is a major public health issue. There's been a growing recognition of the prevalence of trauma and the need to respond to it and how it impacts health for a long time. And really in the last 30 or 40 years, this area of research and practice has picked up. So just some examples. There are over 10 million people living in relationships that involve domestic violence in the United States. Almost half a million sexual assaults in persons 12 and older, and 60,000 assaults of children under the age of 12 every year in the United States. And then remember our US military veterans, of which there are 19 million living in the US, and approximately 2 to 4 million of those military veterans have been combat exposed. It's also important to remember that everyday things that we don't anticipate, such as motor vehicle accidents, 4.8 million people seriously injured in MVIs per year, can cause long-term traumatic responses. And also of interest is that there's a growing recognition that just being a patient in an intensive care unit can contribute to development of PTSD. Essentially anything that an individual perceives as a threat to their bodily integrity can be defined as trauma. And there are over 5 million persons in the ICU every year. I'm sure many of you are very familiar with the adverse childhood experiences, or ACEs, and how they were developed by Dr. Vincent Folletti and Robert Anda and their colleagues at Kaiser Permanente in the 1980s. And it really was based on their observations. They ran an obesity clinic, and they were trying to understand more about why some of their patients were not making progress in their weight loss programs. And I think this is really interesting because it points out that what I'm really trying to convey today is that really it's these ongoing relationships that healthcare providers can form with their patients that can really lead to the most progress. And so in wanting to explore further and talking to their patients, they noticed that there was this high incident of child sexual abuse in these persons coming to their obesity clinic for help, which really surprised them. And then they developed this ACEs measure and expanded it somewhat over time, and revealed that in their primary care clinics, there was a high incidence of adverse childhood experiences among their patients, especially their patients with chronic conditions. Now, the ACE items are broadly in the categories of abuse, neglect, and household dysfunctions. So they break abuse down into physical, emotional, and sexual abuse, and neglect, physical and emotional. And household dysfunction is someone in the household struggling with substance abuse issues, mental illness. Is domestic violence prevalent or present in the household? Somebody incarcerated, and parental separation from either divorce or a death or a disappearance happens sometimes as well. And those asterisk items were items that were added later as they learned more about some of the adverse childhood experiences. Now, you may notice, and you may have heard critiques of the ACE items, that they don't really cover a lot of other areas that could definitely, of course, contribute to someone's poor health and poor mental health. For example, they don't really cover the social determinants of health. So that's been one critique, but what has been very interesting about the ACEs is that despite these limitations, it has been very, very robust, over thousands of studies showing the intersections with ACEs and health. So I looked up, I was curious to see how the ACEs were among children in Hawaii. The National Survey of Children's Health, which was the most recent one I could find, showed that children in Hawaii are doing pretty well in terms of their ACEs compared with the US, children in the US generally. So that was a nice thing to see. Now, most states or all states conduct the brief, the BRFSS, the brief, I can't remember always what it stands for, but the surveillance system. And some of them incorporate an ACEs measure into that. So in the 2015 BRFSS, they found that over 40% of adults in Hawaii had never experienced any ACEs as children, which is really lovely and a high number. And that a little over 20% had one, and then going down to a little over 10%, two, under 10%, three, and then popping up a little bit again with 4+. And the reason why 4+ is really an important number is that multiple studies, starting with the original developers of the ACEs, found that once you hit that number 4, it's sort of a magic number, that a whole slew of healthcare issues are statistically significantly more likely to occur in adults who have been exposed to 4 or more ACEs. And then when you hit the number 6, you find that there's a statistically significantly higher risk for premature mortality for those who have been exposed to 6 or more ACEs. So really, really interesting stuff. Again, really robust, despite not really being initially developed in a way that we typically think of a psychometric evaluation of a measure being delivered, but it still has been super, super impactful. So number 2 is recognizing, and here we're talking about recognizing how trauma impacts people. So again, the ACEs studies showed these high associations with morbidity and even premature death, and it's been replicated thousands of times. So some of the ways we might talk about this from a physiological standpoint is the concept of allostatic load that was first described by McEwen and others. Hans Selye was looking at stress and how it disrupts normal balance of our central nervous system function, our endocrine and metabolic functions, and our immune system functions. And when we have this increased allostatic load from chronic stress, this becomes now associated with the onset of many chronic conditions, cardiovascular disease, metabolic disorders, and even cognitive function can decline. We could also talk about epigenetic alterations, that DNA methylation, when something in the environment causes a change in that DNA, and now a protein that shouldn't be made is made, or a protein that should be made is not made, in its response sometimes to a chronic stress or traumatic event. Telomere length, those little caps that sit on the end of your chromosomes and are associated with your longevity, tend to erode or be eroded in people with a history of chronic stress or trauma. Again, the social determinants of health, they are also shown to be in association with worse measures of social determinants of health in persons with a trauma history, including lower income, lower educational attainment, and all the downstream effects that occur with those situations. Then, of course, you're familiar with post-traumatic stress disorder and the long-term health and life course consequences of PTSD from exposure to a life-threatening trauma. So this is just where, again, you're showing the sum of these medical conditions and how with 1, 2, 3, and 4+ ACEs, you'll just see the odds ratios are increasing: 1.36, 1.49, 1.7, 1.95, and they just become higher and higher across all these multiple types of medical and mental health issues, including substance use. They found risky sexual behavior, including multiple sex partners and transmission of sexually transmitted infections, to be higher amongst people with higher ACEs, and even things like not exercising as much as they should, being a victim of violence, perhaps due to learned behavior or neurobiological changes that occur when you're exposed to chronic stressful situations. So it's important to realize that there's an impact of trauma on the brain, and acute impacts include that limbic system alterations when your brain perceives something as threatening, and your amygdala then sets off a whole cascade of hormones and endocrine changes that occur. And essentially what's going on with that flood of hormones and sympathetic nervous system neurotransmitters is that our frontal lobe stops engaging as well. And so in some of the really acute impacts, and this can occur chronically, or when people are triggered by something that reminds them or reminds their brain unconsciously of the trauma that they've experienced, that they are less able to engage their executive functioning. And this results in slower thinking. It can look like inattention to somebody else, and they may respond in ways that are demonstrate that they're not really thinking clearly, or ways that we might not really expect as typical behavior. It's also important to realize there are chronic impacts. This image here, this neuroimaging, shows that in a person who's been exposed to a lot of abuse as a child has some shrinking and less activity in their temporal lobes. And so the temporal lobes are associated with a lot of emotional processing, attention. And so when you think about a person who's been exposed to a lot of trauma, you might see attention deficits, you might see learning difficulties. And then as healthcare providers, I always want to remind you to realize how trauma exposure impacts you, either in your own history of trauma, since trauma is prevalent. You can't assume that we and our associates haven't also had some exposure to trauma in their lives, but the vicarious traumatization that as healthcare providers and people who work with others in vulnerable populations can experience. This can also be manifested as compassion fatigue, when you just feel like you are tired of giving and giving all the time. And then burnout can also ensue when you have especially organizational and workplace factors that are not supportive. It's really important to promote peer support. A lot of programs, including the forensic nursing program, the hospital where I work has a peer support program. So if we are feeling troubled and we don't want to talk to our direct supervisor or direct peers, they have peers who are there to provide confidential peer support to you. That's a really important intervention. Social connections with your faith groups, with your family, with your friends are really, really important protectors for you as people who take care of persons in vulnerable populations, and remembering your self-care. And I know that's something people talk about a lot, but it's important to do it. Number 3, the third R is responding, and how we can respond with policies, procedures, practices, and settings even that prevent further trauma. And this is when all staff in a healthcare facility, from the person at the front desk to the people cleaning the floors, to the medical assistants, to the pharmacists, to the healthcare providers, the nurses, the doctors, the PAs, the DOs, etc., the nurse practitioners, all staff are applying the 6 principles of trauma-informed care all day, every day, and with all patients. It's really a form of universal precautions for mental health. So these are the do's. These are the things that we should do to respond in ways that promote optimal care for all of our patients. And the ways we do this, going through each principle one at a time, is promoting safety. And I've just put a few ideas on each slide here. One is just to be attuned to patients' body languages, or the people's with whom we work, their body language. Anything that suggests they might feel unsafe, like fidgeting, poor eye contact, or inattention, are quite common. Be reassuring to your patients that you are there for them. If you notice these, observe these behaviors, and again, universally apply these principles. Ask what you can do to help patients feel safe if you observe that they may not be feeling safe. And if they disclose unsafe life situations, it's important to have a plan. There's been research that showed that Oftentimes, healthcare providers don't want to ask about things such as domestic violence or other kinds of abuse in the household because they don't know what to do if a patient disclosed that they are in one of those unsafe life situations. So it's important for everyone with whom you work to know what those resources are in case a patient does disclose an unsafe situation. Promoting trustworthy and transparency. So this is really important that you follow through with the care and that you include patients in their treatment plans and that you avoid surprises. So the 5 traits of trustworthy people: that you're confident, you're authentic, you're professional, you're respectful, and that you accede control. You are in control, but you are also acceding control to patients as experts in their own care. The next one is peer support. It's important to be able to refer patients to support groups, recovery coaches, if they're substance use or mental health recovery coaches, as appropriate, and permit patients to have a support person with them throughout their appointments. Collaboration and mutuality. So this is engaging patients in discussions about their treatment options as experts in their own health, and recognizing that although we want them to do what we recommend, it may not be the best choice for them. And so engaging them in that collaborative discussion is critical. Empowerment, voice, and choice is another one of the principles of trauma-informed care, and this involves providing patients with information about their choices and what the consequences might be if they do or do not accept your recommendations, and doing so without judgment. I remember as a nursing student participating in a really wonderful opportunity where we did home visits with patients. And we were told that this one patient, for example, was not compliant, so to speak, with wearing his, I don't know if they still use these, but he had some cellulitis of his lower extremities, and he was supposed to be wearing these sheepskin wraps on his lower legs. And he wasn't apparently following through with that. Well, when we went and visited his home, this was Iowa in August, and it was about 98 degrees in his mobile home that did not have air conditioning. And so the reason he was not wearing those sheepskin wraps was because it was too hot. It was simply too hot. So it's important to ask patients what they think is best for them and understand that their home situations or their environments may not be conducive to some of the recommendations. And so therefore, it takes some more discussion with them, offering choices, and sometimes coming up with creative options. Also, it's important, this is the last principle, to consider cultural, historical, and gender issues. Just having an understanding, even if we don't necessarily feel we understand a culture entirely, that we understand that individuals' cultures do influence how they interpret and make meaning out of the traumatic events, but also how they make meaning out of interpret their healthcare and their healthcare symptoms, and how they accept them and how they receive support and help-seeking behaviors. It's important to provide always a calm environment, an environment that is quiet, has soothing colors. Views of nature are great if that's possible, or at least some live plants. To use signage that is clear and linguistically appropriate in your waiting room. To make sure there's enough space, because not everyone feels comfortable in a crowded space, and to make sure that everything is confidential. So when they're checking in, for example, that they have space to provide information confidentially without feeling like they're being overheard. Later on, they added this number 4, SAMHSA did, and this is resisting re-traumatization. And they realized that giving you the do's was not enough, and they had to also give you some do nots. It's important to not do some things that may cause re-traumatization. First of all, even though you may be trying to understand cultural influences, don't assume that you know a person's cultural influence based only what you can observe about them. Also, don't shame patients when they don't follow your recommendations. Again, try to understand the broader context and why they may not be able to follow through or don't want to. It's important that we don't label patients or the people with whom we work, our clients. For example, instead of using non-compliant or refused treatment, we could talk more about declining or unable to, and then explore those a little further, avoiding terms like frequent flyer. I recently heard a different term, MVP, which stands for multiple visit patient, but it just has a little better connotation. Also, don't again forget to include them in all the decisions about their own care, and don't make assumptions. Ask patients if you have a question. I wanted to illustrate what this trauma-informed healthcare can look like with a little case study that comes from this wonderful book you might want to check out, called Trauma-Informed Healthcare Approaches by Gerber. I want to start by saying that in some ways my job may seem easier in this regard, because as a forensic nurse, I know that my patient has been exposed to trauma. So it's an easy one, right? I apply trauma-informed care because I know the patient in front of me has been exposed to trauma. It's a little more tricky when you're seeing sometimes many, I think I've heard some ridiculous numbers of patients that sometimes you have to see in primary care settings, for example, every day, and not having perhaps the time to talk to them as completely and as thoroughly as you'd like to. But you do have the opportunity over multiple visits to develop relationships with people. And in fact, this can be really, really a good way to develop trust when you have these multiple visits, whereas I only get this one precious 2 or 3 hour period of time with my patients. I just send them off and wish them well. If you're working with patients and clients that you get to form a relationship with over time, you get to then learn more about how you might engage them and not lose them. So if you apply the trauma-informed care principles, you're less likely to lose them. People with a history of trauma have a very difficult time presenting for healthcare. They don't want to put themselves in positions of vulnerability. And so it's very, very important that we do all we can to keep them engaged. So this was a great case study about a gentleman named Mr. Jones. He was a 56-year-old Black male, and he came in for the first time to their primary care clinic with a complaint of headaches. He apparently preferred coming to the evening clinic because there were fewer people there. On his initial visit, he came in with his wife. He talked about his headache, described it as sharp, severe, and blinding over the past 4 years, and it had been getting worse lately. It was primarily the pain was located in the back of his head. And when he removed his hat, the healthcare provider noticed there was an old, large surgical scar at the nape of his neck with a hardened nodule or some kind of object at the base. And the patient said, "It's a bullet, doc." Most of the talking at the visit was done by his wife, who stated that he's had a headache since his accident 4 years ago. And she said, "We've been to a lot of doctors and no one really gives him a chance." The patient said, "I don't want no problems, just give me my pills and I'll leave." The healthcare provider encouraged him to stay for further evaluation, but the patient jumped off the table and left. However, enough rapport was established that the patient did come back, thankfully. He at least felt listened to. And so on a subsequent visit, he came in alone, and he told this same healthcare provider, whenever possible, it's important to have the same provider throughout a person's treatment. And this time, Mr. Jones was ready to talk about the accident. And he told the healthcare provider that one day he and his friend were driving in his friend's new car. And unfortunately, in that neighborhood, that was perceived as showing off, or what they called flossing. So the neighbors really didn't like that show of his friends showing off that he had this fancy new car. And so when they were driving around the neighborhood, 2 men ran up and they shot both him and his friend. His quotes, execution style, and ran off. And his friend did not survive. So Mr. Jones was in the hospital for over a month and said that he was messed up for a while after that. Still has occasional nightmares about the event. Unfortunately, he's unable to leave the neighborhood. He's still, or fortunately, however you might look at it, but living in the same neighborhood, he does not go out much anymore. He's mostly stays home with his wife and has people come visit in. So over a series, again, of several visits, Mr. Jones is relating more and more and building trust and rapport with his healthcare team. So he's coming in with his wife, and he always, again, comes to the evening clinic because he feels safer then. And eventually he agreed to have his medical records released and to accept medication, a regimen of tramadol and ibuprofen for his severe headaches. And then they were able to arrange finally for removal of the bullet that was still in his neck. And at one point, Mr. Jones expressed surprise because no doctor ever did anything for him in the past, was his experience or his perception of his experience. He did finally agree to take antidepressants, but he continued to decline counseling. But the doctor, primary care provider, felt like that was a lot of progress. So that is a true story that came from that book that I read, and just serves to illustrate how forming those relationships over time, if you're applying those trauma-informed care principles, you can understand and learn more about some of those traumatic events and how they're impacting current health. That one may have been a little bit more direct there because there was an actual physical cause as well as a psychological cause for some of his symptoms and trauma. But that is all I have. And I know I went through that super fast to leave time for discussion and questions. So thank you for listening.
Thank you, Dr. Downing. Any questions or comments, or anyone have a case they'd like to present to the group? Feel free to unmute, or you can drop it in the chat.
Zero, 1, 2, 3. I don't. Oh, this number 333.
333.
Yeah.
Okay.
Yeah.
I think he was unmuted by accident. Okay, here we have a question. We have a comment. Appreciate your info and illustrates that words matter and that people know when you care. Wondering how you help actively suicidal patients.
Is that a question for me? If it is, I have to say that that is something that really is troubling to me. It may not be a surprise to many of you that Texas is a state that has not a very high mental health care provider to population ratio. And so I work in a level 3 trauma center right now. So we do not have psychiatrists on call around the clock. In Texas, we have a system called MHMR, which used to stand for mental health, mental retardation, but they fortunately have kept the acronym but changed it to My Health, or My Resources, My Health, or and My Health, My Resources, sorry. But it's really for people who don't have any other resources. It has not a very good reputation. So occasionally a physician, I will go and talk to the licensed healthcare provider after I've been with the patient and I've learned that they have some suicidal thoughts. And if they are concerned about their immediate safety, they might call for this MHMR on-call person to come. And it seems to me they do a pretty cursory workup and recommend them for placement. Again, these are in, we don't have an inpatient. We have a couple of beds that we call psych beds, but they're mainly either in our ICU or in our emergency room. So Unfortunately, what really most of the time happens is that the doctor will determine that they're not an immediate risk to themselves and get them to say that they're not, and then send them home and recommend that they have some follow-up counseling. Not a very satisfying option. Sadly, I much prefer working at level 1 trauma centers where you have your 24-hour on-call psychiatry practitioner, but it's not a very satisfying answer. Unfortunately, sometimes if I've really been concerned, I have talked to their support person. Oftentimes they come with a family member or a friend, and I will say, do not leave your friend alone tonight, at least stay with them for the next 24 hours, see how they're doing, make sure that they're doing okay. Don't leave them alone if I'm really concerned about their immediate safety.
Thank you. Yeah, Ella just comments that there are mental health shortages, mental health provider shortages almost everywhere, especially here in our rural island state. Another question, how can you help someone that doesn't want to heal past the trauma because maybe they feel they deserve it?
Right. So again, not having the good fortune to have the long-term relationship with patients, probably the most common or the closest thing I've had to that is patients who feel as though the sexual assault that they just experienced or the domestic violence that they just experienced is because they deserved it, right? And here now, oftentimes they are seeking help because somebody else told them to come to the hospital and not themselves. So I think that would be a much more longer term relationship with somebody and getting to the bottom of what their self-esteem issues. And so that is unfortunately beyond what my experience has been. However, we do recommend always multiple times and we have an advocate present at all of our exams. We don't ask the patients, hey, and this is something to consider too, and which is why, integrated behavioral health is so important. Instead of asking people, would you like to see our psychologist or would you like to have an advocate called, we have the advocate come to the hospital, and then that person, that advocate, presents themselves to the patient and says, hi, I'm Joy, and here's what I'm here to provide you. Would you like me to stay with you throughout the exam? And here's the things I can do for you. And almost invariably they say yes. But if you ask them, do you want me to call an advocate? Then they're going to say, no, that's okay. I don't want to trouble anybody. Or so it's how you also approach that. If you have behavioral health integration, you can just, again, hey, here's Dr. So-and-so. They want us to talk to you. Is a good way to do that and build that long-term trust.
Karen says, thank you for the PowerPoints. Are they available? And yes, they will be available on our ECHO resource page. I'll drop the link here. She also has a question if you could further elaborate on the chronic illness incidents related to trauma history.
Sure. So specifically, are you asking about the pathophysiological
Yes,
pathway?
yes, yes.
Okay, yes. So my presentation was a very superficial overview. If anybody's interested, I do have a lot of the scientific references that support everything I said. But really what we see is a lot of disruption of normal pathology, right? So the first thing we think of when we think of chronic stress is the HPA axis, right? Your hypothalamic pituitary adrenal axis. So if you think back to your science classes, right, you have your brain releasing a hormone to your pituitary gland that releases a hormone to your adrenal glands that sit on top of your little renal, your kidneys, and pumps out cortisol. So if you have, cortisol is a really wonderful, amazing substance when you're undergoing an acute traumatic situation. So say you get in a car accident, your body cranks out cortisol. That helps you maybe not feel pain for a minute, tamp inflammation enough that you can like get out, escape that car in case it's about to blow up, right? Or do what you need to do to get to immediate safety. But if you are experiencing chronic stress and you have chronic elevated cortisol, after time, that chronically elevated cortisol can cause changes in your immune functioning that then can dampen your immune response, can contribute to autoimmune conditions, can contribute to just long-term disruptions in your appropriate metabolic pathways. So people with lots of elevated cortisols might have that Cushing type appearance where they may have, a protruding abdomen is a common sign of chronic hypercortisolemia. So that's one pathway. Another pathway is, again, that sympathetic nervous system dysregulation and hyper. So you have your epinephrine, which is chronically elevated, and so your amygdala, again, sometimes often unconsciously, is perceiving things as threats that wouldn't normally be a threat if you hadn't somehow been exposed to a traumatic situation. So now you're pumping out too much epinephrine or adrenaline, right? And so your blood pressure is chronically high, your pulse is chronically elevated. And so over time that could lead to, your blood vessels getting damaged. And so that can even contribute to the development of diabetes, heart disease. So it's really, the connections are really quite direct. They're not even very indirect. So those dysregulations of the HPA axis and that cortisol dysregulation and sympathetic nervous system dysregulation are the two primary pathways that are disrupted with chronic stress.
Oh, thank you so much. That's just exactly, what I was asking for. And also these references that you spoke of, will they be attached with the PowerPoints for additional reading resource?
There are some in the notes areas of the slides. There's a lot of, if you just email me, because I have a book chapter on like a lot of the stress responses that I wrote for easy understanding, I'd be happy to send you that, and it has all the references too.
Okay, thank you.
Sure.
Thank you, Karen. Thank you, Dr. Downing. Any other questions? And Rhonda just says it was an excellent idea to just provide support versus asking first in the earlier question about the trauma, not wanting to heal from trauma, past trauma, because they feel they deserve it. We have another question from Taryn. What are some good examples of workplace policies that are trauma informed?
Oh yeah, that's a great one. It's become quite a important discussion in the last few years, I know. So, it's really interesting. I do some research in burnout and healthcare provider burnout, and something that people don't always appreciate when we talk about burnout is that it really refers to workplace stressors and organizational stressors. A lot of people think it has to do with things that you as a healthcare provider are doing wrong, that if you would only do A, B, and C, you wouldn't be burned out. When really a lot of it has to do with working in an environment where you're not getting support. So I've even worked with people who are not very friendly and kind to their coworkers, but they can switch on their trauma-informed care when they're working with the patient. Whereas really, we should assume that all of us, there really is an artificial distinction, right, between providers and patients, because even providers are patients sometimes, right? So treating each other with the same trauma-informed care principles is important, and that starts with our administration down. Now, obviously, myself as an employer, I can't go to my, the CEO of my hospital and tell him to be, trauma-informed, or my manager to be trauma-informed. But some examples of what that might look like is, again, just asking people, it's amazing if you just ask people, how are you doing? How's your day going? My manager will reach out to me and say, I looked over your chart and you had a really tough case last night. How are you doing? You doing okay? Do you need to talk to somebody? You want to talk to somebody? You want to debrief? So just being a person who is willing to reach out and ask how you're doing. Flexible scheduling, we know this is important in a workplace. I worked in a place where we had self-scheduling. So we, put out, these are your mandatory weekends. Now go in there and write what your preferred schedule is. If you didn't get the weekend off that you wanted, you just traded with your, coworkers. So just having policies in place where people's family lives, their private lives, their personal lives are respected, and everyone's willing to make accommodations for it. We have a group chat with my SANE sisters, as we call each other, because we just do happen to be all female. And if one of us has an issue, we'll text and say, hey, can anybody cover call for me? Like, my child is sick. And somebody will invariably text, hey, I got your back. And, that's the kind of environment you want to promote. I do think leadership is so important. If there's nothing I haven't learned since 2020, is that leadership is important, right? And setting that tone from the top down. So I would just implore you that if you're the supervisor of anyone, that you set a tone where that trauma-informed care infuses across your whole workplace, and apply those principles to your workforce, if that is helpful at all.
Very helpful. That's true. Susan says, thank you for that information. Anyone else while we have Dr. Downing here, her expertise here to share with us? Excellent presentation. Thank you.
And her address, is that on the first slide, the email address to contact her at?
I believe it'll be on, let me take a look. Her
On the last slide,
last slide.
Okay.
it's just my last name at tamu.edu for texasamu.edu.
Okay.
I can put it in the chat too. That'd be easy.
Any other last questions or comments? Next week, we have David Spouse. He'll be kicking off our Tuesday ethics. He'll be on, I believe, every second Tuesday of the month to talk about the 12 ethical principles of the Certified Substance Abuse Counselor Code of Ethics. So he'll be talking about that. And this week, if you are on Kauai, our Kauai folks, they have the Ola Opono Kauai Health Conference, their first ever. Dr. Cohn will be emailing you. He says, thank you. A lot of thank yous, Dr. Downing, coming in the chat. Mahalo for your time. Thank you, everyone, for your time. A lot of new participants. If you are new, I see a lot of new names that joined in. There was a lot of interest for your presentation, Dr. Downing. If you're new and wanting to earn CEs for Dr. Downing's presentation, please be sure you do register on our Behavioral Health Echo link, and just please be sure to see all the thank yous and mahalos coming through the chat. Very, very grateful.
Thank you so much.
Lydia, I have the information for the Kauai conference. If you email me, I can send it over. Let me just drop my email in. Thank you, everyone. And thank you, Dr. Downing, again. Have a great week, everybody.
Take care, everyone.